Hello, my name is Jackie Fletcher and I'm the clinical lead for the Stop the Pressure programme for the National Wound Care Strategy, and I'm joined today by Kate Williams from the Society of Tissue Viability. We're going to talk to you about pressure ulcer risk assessment and why it matters so much. If we're going to understand risk assessment, it's important to understand the process that it involves. So we start with the identification of specific risk factors relative to the patient that we're caring for, and we use those to build a picture of their level of risk. This allows us to stratify patients into groups, those at risk and those not at risk. And this is important to help us make the best use of the resources we have, whether that be the personnel resource, so those people involved in repositioning the patients, ensuring they have adequate diet and hydration, or whether it be the use of equipment such as pressure redistributing mattresses, cushions and chairs. Implementing the appropriate resources will ultimately be the thing that helps us ensure we have a better outcome of care for a patient, i.e. that they don't go on to develop a pressure ulcer. Whilst the process of risk assessment may seem quite straightforward, you have your patient, you complete your risk assessment tool and you plan care. In the reality of clinical practice, we know it's much more complex than that, and there are many factors that may influence our ability to carry out a thorough and detailed risk assessment. Whether that be our most common complaint, we're short of time, or it be around knowledge and skills and the ability to carry it out. It may be about our ability to input things into electronic patient records, or a whole host of other things like not having appropriate equipment to weigh the patient or measure their upper arm circumference. What we do know is that it's not a straightforward process in itself. So I mentioned that risk factors were a key part in this, and it's important to understand those that are evidence-based. So Suzanne Coleman and her team carried out a systematic literature review of part of the 2014 international guidelines, and they identified groupings of main risk factors and broke these down into two areas: the mechanical boundary conditions and the susceptibility and tolerance of the individual. The mechanical boundary conditions include the magnitude and duration of the load. And by load, we mean the shear, pressure or friction. So we need to know how much pressure the patient has had and for how long. So for example, if somebody sat on their sofa for a short period of time, that's a low amount of pressure for a short time. But if they have a fall and they lie down on a hard floor, then that's a high amount of pressure for a long time. Susceptibility and tolerance of the individual we used to call internal or intrinsic factors, things about the patient. And those would include things like, is it over a bony prominence? Is there a reduction in their mobility? What's their perfusion and their circulation like? And when we bring that together with the amount of load, we look at the level of risk of the patient of developing a pressure ulcer. As well as knowing the correct risk factors, it's important to do the risk assessment in a timely way. And we have guidance from NICE that tells us when we should be doing our risk assessment. If you're in the acute setting, it should be within 6 hours of admission. If you're in community, it should be on your first visit. But each of those has some queries. So when we talk about within 6 hours of admission to acute, we might want to consider what our organisation understands by when that 6-hour clock starts. Is it when that patient comes into the A&E department, so when the receptionist sees them? Or is it when they've been triaged, seen by a clinician? Or is it actually when a decision has been made to admit? And I think there's some discrepancy about how this is applied across the country. But my personal view is if the patient has been seen by a nurse, then there's already a responsibility to that patient, and we need to think about making sure they have a risk assessment within 6 hours of that point. In community, this was always a straightforward question. It was on the first visit. But as we've seen during the recent pandemic, that first visit isn't always an actual visit to the patient. We are more and more seeing patients being spoken to by telephone or by video consultation. And we need to be clear that a first visit would include those kind of contacts. We also need to think about who that contact might be with. Not all patients see a nurse. And we also need to understand that risk assessment isn't just about what nurses do. It's about what any healthcare professional does when they contact the patient. So many patients come to us having seen other healthcare professionals, but still having developed a pressure ulcer. So we need to ensure that our AHP colleagues are very aware of risk assessment and know what they can do to help prevent the patient developing pressure ulcers. So you can see some examples on the slide here of community pharmacists may have been seeing a patient or a patient's relative asking for dressings or creams for sore bottoms. And what could they do to find out why that patient needed those? Think about the paramedics who may go in to see a patient who's had a fall, and if that patient hasn't broken a bone or has not got any obvious injury, they may return them to the bed or to their chair and leave them in their own home setting. But we need to know how long that patient was lying on the floor for. They may have been on the floor for a couple of hours before they got help. It may take 90 minutes for the ambulance to get there, and if they're on a cold, hard floor, their risk is significant. Equally, think about the different types of therapists, particularly in a rehabilitation situation, who may be going to see a patient who has no nursing contact. What can they do to help either screen or risk assess and flag to the nurses that we need to do something to help prevent pressure ulcers occurring?
Hi, I'm Kate Williams. I am one of the trustees of the Society of Tissue Viability, and now following on from what Jackie has just been discussing, I'm going to go through how you assess risk. So what are the options? So we have two things to hand. We have risk assessment tools and our own clinical judgment. So clinical judgment is quite a vague, ambiguous term, but really when you think about it practically, it's from a pressure ulcer point of view. Sometimes you might do a risk assessment and it might say that the patient even might not be at risk, but you know from looking at them that you want to complete a full risk assessment. Something's not quite right, something's telling you that you need to do more. So it's a combination of your own experience, your ability to reflect and think about clinical reasoning. So it's just, so this individual patient needs something extra. So the risk assessment tool is there to guide you, almost like an aid memoir, but your clinical judgment is key. So if you think of clinical judgment as the golden thread that runs through all your risk assessments, whether it be a pressure ulcer risk assessment or falls or any other assessment tool you might use, good clinical judgment is really important to try and apply that tool to a person. So an individual with their own circumstances, their own needs. So it's really important that you use a combination of both and that you don't just rely on a tool. So you can see from this slide that there's many risk assessment tools that you could be using in practice. I'm sure you're familiar with many of these. I know I've used many of these over the years in practice, but the tool which we are going to focus on today is Purpose T. So we're focusing on Purpose T because this is the risk assessment tool which is being recommended by NHS England. It's also recommended by NHS Wales, and other areas of the UK, Northern Ireland, Scotland are looking at possibly implementing Purpose T also. So the reason NHS England have chosen to encourage the use of Purpose T is that it is the most evidence-based. It was developed using robust research methods, and as part of our suite of resources for Stop the Pressure Week, there is access to a webinar by Suzanne Coleman and Jane Nixon, who developed Purpose T. So I would highly recommend, if you haven't watched it already, that you go and watch that, because it gives much more detail into the research methods that were used and how this tool was developed, how they narrowed it down to 7 risk factors when they started with so many. So it's really useful, and it would help you apply this tool in your clinical practice if you understand the research methods behind its development. So one of the big changes was that it included detailed skin assessment. So this is something which was an international guidance anyway, but it wasn't really a common thing in other risk assessment tools. And for me personally, in my own clinical practice, any of the risk assessment tools I'd used previously didn't include a detailed skin assessment. So that was a really positive change. Purpose T also identifies people with and who have previously had pressure ulcers, which again is something new compared to other risk assessment tools. So if you're new to Purpose T, please do get in touch with the Clinical Trials Research Unit at Leeds University. There's a link here on the slide. If you're considering using Purpose T in clinical practice, please get in touch with the team at Leeds University and register your interest, and they can help you. So this is Purpose T in its paper format. It has been modified and adapted to electronic versions. The majority of clinical areas now use electronic patient records, so Purpose T is compatible with systems such as System 1, EMIS and others. So if you want to find out more about the electronic versions of Purpose T, please just get in touch with the Clinical Trials Research Unit at Leeds and they can advise you on that. So we're going to go through it in more detail now, but the main thing to notice is that there is no numerical score. So at the end of this risk assessment tool, the patient is either red, amber or green, so they either have a pressure ulcer or they have scarring from a previous pressure ulcer. They have no pressure ulcer but they're at risk, which would be amber, or they have no pressure ulcer and they're not at risk. Interestingly, the decision as to whether somebody is amber or green is influenced by clinical judgment, not just ticking boxes, which is something which we're new to some of you. So the first part you'll complete on Purpose T is the screening section. So the idea of the screening section is to screen those people who aren't at risk of pressure damage, so you don't need to go on and complete the full Purpose T. So it's a time-saving exercise really for those patients who are really obviously not at risk. So there's 3 sections to it: mobility status, skin status, and also clinical judgment. And that's a recurring theme in this presentation and in Purpose T, the use of clinical judgment. So with mobility, I won't go through it in detail, but depending on which box you tick, if the person walks independently with or without aids, then you'd move across to the right to the next box. If, however, you ticked a yellow box here, you just move straight down under the full risk assessment. For me, one of the pointers which I feel is important here is it's the kind of conversations you have with people and how you ask these questions. And I think it's important to consider day-night variation with your patients. So more so for community settings maybe, but just because somebody can walk and greet at the door, don't assume that they're able to reposition themselves in bed at night. So for example, a patient who might have had hip surgery might only be able to sleep on their back. So just things like that. I've known patients who have slept on the couch and always sleep on their side all night long. So until we ask them about their nighttime routines, habits, and if they're able to change their own position, just toss and turn in bed like you or I would, then we don't really get a full picture of their 24-hour pressure ulcer risk. The next section is skin status. So one of the questions we often get asked about this is, do we really have to ask mobile younger patients for if we can look at their skin? And the answer is no. We need to apply some element of common sense to this. You're not going to ask a 25-year-old who's coming for wrist surgery to look at his skin. So it's about applying some common sense, using your own clinical judgment. But if there are elderly people and people who you think, just by looking at them, you know what the risk factors are for pressure ulcer risk, it's the question of can I check your skin is worth pursuing with some patients more than others. So if a patient reports no problem, skin's fine, no dryness, no soreness, no scratches or breaks, then you can take their word for it. But you might want to pursue that further with patients who you can see, for example, you can see on some patients, they might have really thin skin on their hands or arms, or they might look as if they've lost some weight, their clothes might be quite loose. So you know that they might be more vulnerable, and for those patients that conversation might be worth pursuing. Can we just have a quick check of your skin? Again, if that's blue, if the patient has normal skin, then you'd go on to clinical judgment. So that's when that just gives you the ability to overrule it really and decide, I'm not sure, there's something here. They might be 25, but they've had an epidural, so I'm going to do a full risk assessment. So it's all about your clinical judgment there. So the screening section is there to save time, but if there's any yellow boxes, just move down, complete the full risk assessment. So as you move on to the full assessment section is step 2. You can see here that there's each separate risk factor is identified, and the idea of this and the way I like to use it is that each bit highlights to you where a problem might be and where you can target your care planning. So for example, if the patient has a problem with nutrition, we need a plan in place to address that. If they've got a medical device, we need a plan in place to mitigate that risk. If their diabetes isn't well controlled, we need a plan in place to mitigate that. So it's all about targeting your planning to reduce the risks that you identify here. So one part of this you can see, we're going to go through it in more detail now, but an interesting part is that it's the detailed skin assessment includes scarring from previous pressure damage. So this flags up as instantly red, and this is because when someone has a scar from previous pressure damage, we all know that as scar tissue is not the same as normal healthy tissue that's not been damaged before, and therefore it's at more risk of breaking down. So Purpose T does highlight scar tissue. It's a really good opportunity then to have that discussion with the patient, saying, well, your skin's okay, but you have got a scar. Have you had a pressure ulcer before? So it opens up those conversations where you can just revisit their personal risk factors, how it happened before, what situation were they in, is this another situation that's similar, and explain to them that this might be a lifelong thing that they need to live with, and just be aware of if they have episodes of ill health. So the first section you come to is analysis of independent movement. So you can see here the variations as doesn't move, slight position changes and major position changes. So the differences in that language really, major position changes is when somebody is completely offloading from their pressure areas, whereas slight position changes might just apply to small shifts in posture or tilting or leaning. An example would be a wheelchair patient who might readjust their position all the time, but just by leaning forward, leaning back, lifting themselves up for a few seconds. So that would be slight position changes, where major position changes would be mobilising or being physically repositioned. An important thing to think about with this really is the fact that some patients can mobilise, but they choose not to. And so for these patients, we need to figure out why. It's not just about ticking a box, it's about why do they choose not to mobilise. Is it related to their mood? Do they have pain? So when they move, they're in pain. Are they on medication that makes them feel drowsy, so they're afraid of falling? Have they had previous falls, which just exacerbates that fear of falling? And so it's just trying to figure out why, and working with our AHP colleagues, so asking our physios to assess the patients, asking the OTs to see can they make them more independent. And so people are more confident mobilising or even just moving in a bed or in the chair independently, just to get more independent movement. I think something to consider here as well is the role of the family and carers. So you might have an elderly person who is able to reposition, but through sheer kindness, the carers or family members might make them less mobile. So examples would be bringing them dinners on a tray, having overchair tables when really they could walk to the dinner table. So it's all through kindness and care, but really the patient is less mobile. If elderly people can stand and walk to a dinner table, they need to be doing that so that they keep moving. So it's just to have those conversations with patients, carers and families really about encouraging mobilisation. Yes, it seems kind to bring them everything to them, but we need them to move. And then again, the last point here is just about considering that day-night variation in mobility, which we've mentioned already. So with sensory perception and response, there are those patients who may have had a spinal injury, may have a neurological condition, peripheral neuropathy, anything where they're unable to feel discomfort from pressure. But then there's that group who are able to feel discomfort from pressure, but for whatever reason, dementia patients are a really good example, they're not able to communicate that to us in a way which we're understanding. So a dementia patient might scratch, they might fidget, they might seem agitated almost. I've seen all these examples in clinical practice where patients with dementia are uncomfortable, and for you and I, we could just move our own position, or if we were unable to do that, we could say to somebody, I feel uncomfortable, my bottom feels sore. But for some of these dementia patients, they're not able to communicate that discomfort, so they might demonstrate that in non-verbal or less typical ways. But we have to think about how people communicate discomfort from pressure to us in different ways. And then with perfusion, you can see that both the amber boxes here relate to perfusion, but different areas of the body would be at risk depending on which box you tick. So again, it's not just about ticking a box and going, oh, they're amber. You need to really look at the box you are ticking and think, right, if this person has perfusion problems because they've got peripheral vascular disease, then we need to focus on their heels and their feet. If they've got perfusion problems because they've got hypertension or heart failure, we need to think about other parts of the body. So you can see here that for patients with the upper amber box or conditions affecting central circulation such as shock, heart failure or hypertension, inevitably they would be more likely to need a mattress, whereas patients who have got conditions affecting peripheral circulation, so peripheral vascular disease for example, they probably wouldn't need a mattress. We could use more specific offloading equipment that focuses on the heels. So again, it's not just about ticking a box, it's not just about getting red, amber, green, it's about thinking the wording in each box, how is this affecting my patient and how can I prevent their risk? So we know from looking at Purpose T that when we tick a yellow box, it means that we have to use our own clinical judgment. But the yellow boxes are really important, and it's up to you to determine whether this is going to impact on somebody's pressure risk. So moisture, nutrition and diabetes, for example, all these are yellow boxes, but there's some questions here, just prompts to try and consider when you're risk assessing your patients. So with the moisture section, for example, is the moisture well managed? Is the skin well hydrated? Is an appropriate plan in place? So are appropriate cleansers and emollients being used, or in some cases barriers may be necessary? So how is that condition managed? You might have a patient who's incontinent. Do they manage it well? You might have a larger patient, some of the bariatric patients, they can have problems with heat and sweat during the summer. Are they able to manage that independently? Are their carers aware of that? Is it all well managed? If so, the risk of them developing pressure damage is much lower. So this is where your clinical judgment comes in. Again, with nutrition, poor nutrition always needs addressing, but you need to determine, is that impacting on their pressure ulcer risk? And it's how it links in with all other factors. So if you've got somebody who has got a low body weight but is independently mobile, no other risk factors, moves independently day and night in bed, they're able to reposition themselves, then you might decide that that patient isn't at risk. The same for diabetes. Is the diabetes well controlled? Are there other risk factors, specifically neuropathy and then reduced nighttime mobility? But it's all about the conversations you have with your patients. So if you think for community staff, if you go and see an elderly patient, first time you've met them, and from doing Purpose T and having a conversation with them, you decide that they're not at risk, even though they are slightly underweight and they have some urinary incontinence. The kind of conversations that really matter, because remember, this isn't just about ticking a box and filling in a form. This is about figuring out how to prevent your patient from getting a pressure ulcer at any stage. So today, that patient might not be at risk of pressure damage, and you can explain that to them. But what's important is, this is an elderly person living alone at home. We need to start those conversations saying, look, you're not at risk of pressure damage today, but should you have a period when you're not well, if you're not up and about quite so much, if you have to, if you take to your bed for a couple of days because you don't feel so well, that's when that patient can suddenly tip into high risk of pressure damage. And they need to understand that. It's about starting to educate people about their own risk factors and how that might suddenly increase should they have a period of ill health. And sometimes it's just as important to have these discussions with carers and family members so that people understand. So maybe mum might not be at risk of a pressure ulcer today, but I can see she's at risk of chest infections. She's had a couple of chest infections over the past 12 months. If she gets another one, we need to really keep an eye on her skin. We might have to change things, get her a better cushion. We might have to spend some time in bed, that kind of thing. So it's more about thinking about how am I actually reducing the risk of pressure damage for my patient, rather than how do I fill out Purpose T. As I've already mentioned, Purpose T considers a patient's previous pressure ulcer history, and a history of pressure ulcers would lead to a yellow tick box, as you can see, but the presence of a scar means that the area will be always vulnerable to pressure, and so from a Purpose T point of view it will always be red. So this again is just another conversation opener with the patient. You're going to be at risk. This is a lifelong risk for you because you've got a scar. Depending on their age and ability and other conditions, you need to have those conversations with them or their carers or their family, and make sure that people understand the lifelong risk which comes with having a scar from previous pressure damage. So this is the skin assessment section. You can see that listed are the most common sites for pressure damage, but then there's also spaces there for you to fill out other areas. So some patients might have other vulnerable areas, for example their spines, then also considering patients who have contractures or patients who have postural changes. They might lean to one side, so it's important that you identify those other areas that are at risk and document them in the spaces there. So then as you go through, you can see that you need to identify if they have pain over any of these pressure areas. Does the skin look vulnerable? Does it feel vulnerable? Is there already some pressure damage there, or is the skin normal? So this will then flag up more yellow, amber and red or blue boxes, and will help you decide again how you're going to reduce the risk for this patient. So certain sites on the body looking vulnerable might need more targeted risk mitigation. So the next few slides are just going to focus on two specific areas, so that's heels and device related pressure damage. So if your patient's heels are at risk because of poor blood supply, diabetes, diabetic neuropathy, think about what they need. Do they need a higher specification mattress, or do they need some specific heel offloading devices? Think about if you're going to go for heel offloading devices, think about the kind of device you're choosing. If necessary, get some advice from your tissue viability team or podiatry team, and think about what is going to work best for that patient long term. Some offloading devices are not suitable for patients because they might not stay on, they might not find them comfortable. So we need to really focus on planning lifelong pressure relief for these patients where necessary. So we can really look at the heels specifically, and please do work with your podiatry colleagues. They are experts in all things heels, feet and offloading, so please do refer on to your podiatry colleagues. So this is an example of the Purpose T boxes, for want of a better word, which would be jumping out for patients who are at risk of heel damage. So patients with conditions affecting their central circulation, patients with conditions affecting their peripheral circulation, diabetes, and those with any sensory perception issues where they cannot respond to or report discomfort over pressure areas. So just take a little bit of time reading through this. This lists the internal and external risk factors for device related damage. So what you need to do is really understand the devices that you use in your clinical area, regardless of which clinical area that is. Understand the devices which you use and how they might cause skin damage to your patients. People have asked in the past if we need specific risk assessment tools for device related pressure ulcers. No, we don't. We just need to understand that if a patient has a device, they are at risk of developing a device related pressure ulcer. And it's about your understanding of the devices you use in your clinical area and the appropriate ways of offloading pressure. So what comes next? You've done your Purpose T risk assessment. Next, you need to manage that risk. So you can see from your purpose T which aspects of that person's clinical condition means that they are at risk of developing a pressure ulcer. So it's the most important thing is the care plans that come from the risk assessment. This isn't just about doing a purpose T, tick box, done, lovely, that person's at risk. We need to think which bits put them at risk and what are we going to do about it. And it's the quality of that planning and how well it is implemented and reviewed that will prevent the pressure damage, not the risk assessment tool itself. It's what you do with the information which the risk assessment tool prompts you to glean from your patient and from your assessment. So now about risk assessment. So you've assessed your patient, you've got care plans in place to mitigate that risk. Now we have to think about how often we need to reassess that risk. How often do we need to redo purpose T? So this is really determined by your local policy, but it should always be done if the patient's condition changes and if the patient is transferred from a different care setting. So this would include going to theatre, it would include moving from a care home back to their own home or vice versa, or moving from ward to ward, moving from A&E to a ward. So it's any changing, any transfer of patients needs to have a risk reassessment because their condition could have changed. If the patient is staying in one setting but their clinical condition does change, then they will need reassessing. Some local areas set a time scale, so please do be aware of your local policy, whether there is a set reassessment intervals of monthly, for example, or weekly. It depends on your own clinical area, but please make sure you're aware of your local policy. When it comes to reassessing risk in the community, we need to consider really, this is a lifelong thing for some patients, really, lifelong pressure ulcer risk management. So we need to think about who else can help us. How many patients are being seen by community teams who are at risk, have good prevention plans in place, but have no other clinical need for regular community nurse visits. For some examples there, so maybe patients who have 3 monthly injections, Doppler assessments or catheter changes, or even those patients with no other clinical need at all. So it's about considering, do we discharge them? Do we delegate skin inspection to carers and families with really clear criteria for what to look for, what to escalate back to the teams, and why? So the most important thing is find out in your own local area what are the processes for either discharging patients who are stable, they're at risk of pressure damage, but they've got a good prevention plan in place. Look at the processes within your own organisation. Some will have documentation which might want signing, some won't. Some might have a really clear tick box of things you must discuss before you discharge a patient. Some organisations might prefer you didn't discharge them at all. So it's all about looking at your own organisation. What is the process that's there, and making sure that you follow that and that you work within the policy and guideline of your own organisation.
Thanks, Kate. And I think that really highlights where we started from, doesn't it? That there are so many things that can go wrong, so many differences that happen. And just trying to do that risk assessment, make sure that we're following patients up and that the plan of care is linked to the patient's current condition, not that when that risk assessment was done maybe 3 months previously, can itself be a real challenge. Making sure that people have the right skills, the right knowledge, and that they're doing this thing when they're meant to do it is a really important priority for us. So we need to remember that risk assessment is really important, but we must get it right and must be aware of the things that trip us up when we're trying to do it. So I think that what that reiterates to me is that risk assessment is a skilled task. It can't just be done by anybody, and that it requires time. You need to know your patient. You need to be able to ask them questions and find out about their normal lifestyle, the differences between what you see during the daytime and what happens for them overnight or when you're not there. And it does require confidence and experience as well as knowledge and skill, because knowing something and having the confidence to challenge are two entirely different things. Most importantly, risk assessment isn't a tick box exercise. It's something that should make a difference to the care of your patients. And as Kate said, it's about often a lifelong thing. It doesn't end when that patient leaves your care. You have to continue that by making sure that everybody who's involved with that patient knows about their risk. And make sure in particular that the patient and their family or carers understand that, whether that's a formal or an informal carer. So the final point I want to reiterate is, whilst we've said how important risk assessment is to remember that risk assessment itself is not what prevents pressure ulcers. It's what you do. It's the actions you take on the findings. That's the thing that makes a difference to the patient. So ensure that your risk assessment is threaded through into your plan of care and that you're implementing the appropriate actions. So thank you from Kate and myself, and I do hope you have an enjoyable Stop the Pressure Day. Thank you very much.